Go to the second case. The case of the creeping man. So, Robert, age 53, is an iron worker. Date of injury is 7/20/2013. Date of reported injury was 1 day later.
Lumbar strain, from my standpoint.
And probably
Mild to moderate ankle sprain.
yeah. And from the shoulder injury, you could have a strain of his cuff tear, possibly even a AC joint injury, labral injury.
And the reason for the lower back is because he's twisting to try to stop himself from falling. Because there is a twisting force, a torsional force.
When somebody hits the deck, everybody complains of back pain. So,
Yeah.
and he's not a small person either. So I would entertain, at least initially, any reports and complaints of back pain. I wouldn't completely, I would immediately discount
So
them.
here's his pain diagram, and he listed it 6.5 for the visual analyst scale. Left shoulder, left lower back, left ankle.
Is that the sum total of all of his complaints? That's what I would ask him. Did he add them up individually, or is that just because of his back pain or his ankle pain? What's he referring to exactly?
Yeah, I think that would be important to know how each one is rated differently.
Yeah.
I would expect a mild ankle sprain from this exam.
And that he has most likely either a rotator cuff or biceps tendon type pathology, soft tissue pathology.
The result of the injury? As a result of the injury?
Well, he has a mechanism falling on that shoulder, so I would say yes. Probably would have treat it a little bit differently. But I think that if you feel that somebody has a rotator cuff tear, they fall in, they can't raise their arm up, they have weakness in their rotator cuff, then you might as well do the definitive test immediately. Do an MRI scan and figure that out, because if he's a laborer, you're going to have to fix it anyways. He's probably not going to get better non-operatively. If you think he's strained his shoulder and you say, I think he has a rotator cuff strain or a bicep strain, I don't think it's torn because he has good strength in his shoulder, even though his motion may be limited by pain, then I don't think it's unreasonable to proceed with that type of plan where you're going to do, put him on some medication, probably a little pain medication initially, but most likely a non-steroidal anti-inflammatory, and do some physical therapy. But if it, I always tell the patients, if they come in and they fall and they say, I can't raise my arm up any higher than this, and their strength is horrible, I'm like, well, we need to make sure you don't have a rotator cuff tear right now, because if you have a tear, it's not going to change what I'm going to do. I'm going to tell you you're going to need to have it fixed, especially if you're a laborer. So why wait 4 weeks from now, do a scan and find out you have a rotator cuff tear, and you've wasted 4 weeks of time where you could have had that person rehabilitated.
So you're questioning diagnosis number one because there's no imaging studies to validate it.
Yeah.
And the physical findings are a little off. I mean, if they had a full thickness supraspinatus tear, you wouldn't expect that type of strength, and
Yeah.
so that just seems off.
So if a case manager or a claim adjuster sees this, and the imaging studies have not been done, how do they question that?
Well, I mean, I would question it as the fact that, I mean, obviously you're looking at we talked about already, the examination. He does have some restriction in his motion, which may be related to pain. But if his strength in his cuff is good, then, the odds of him having a rotator cuff tear are very low, although you can have a big guy that can still have fairly good strength and have a small cuff tear. I would, say that, if you're, like I said, if you're concerned about a tear in a laborer, you should do the definitive test. There's no reason to wait. I mean, even if he had a small tear, and you rehabilitated them, and I've seen this so many times. You have a small tear, they're rehabilitated, they don't have any pain. If they have a lawyer, they're gonna want to get it fixed. Because the bottom line is that tear, even though they're not having any pain after rehabilitating it, the tear is there. That tear may propagate over time and cause them to have more problems, specifically if they're a laborer, so you might as well fix it. A small tear is very easy to fix. Outcomes are very good. They usually heal. Larger tears, very hard to fix. Don't heal as well. Sometimes don't heal completely. So small tear you're going to fix. So in that case, you're going to do it anyways. So, I don't see why you would wait.
When do you decide to do an x-ray? I know there's a difference between x-rays and MRI, but what's, because to me, it's like, I'd like to get that picture in time. So when they start prolonging this, we could say, well, wait a minute, this shoulder didn't look like this, several weeks ago.
And I do x-rays every time they come in. I mean, not every time, but if I see somebody new, I'm going to do an x-ray. In this case, a guy like this that's fallen on his shoulder, has limited range of motion of his shoulder. Say he had more weakness in his shoulder. It could be from a rotator cuff tear, it could be from a greater tuberosity fracture, it could be from a proximal humerus fracture, it could be multiple things. So I think you initially have to get an x-ray, number one, to rule out any fractures. All right, x-rays can also give you other information. Say this guy had a chronic rotator cuff tear. That x-ray may show you that his humeral head is elevated in the goniohumeral joint, which would tell me that's a chronic tear, and it may have triggered or precipitated, exacerbated that, become more symptomatic by his injury, but probably had an underlying tear that was already there. So there's some things you can tell from x-rays that will help you that I think you need to get initially. And then the question is just based on your exam. If you really think he has a tear, I had a big laborer come in, he fell on his arm, he's like, I can't get any higher than this. I can raise it up passively, actively, has not good range of motion, has significant decreased strength. And I'd probably say, in that case, you might as well get a scan initially to rule out a tear, because if there's no tear there, then we can treat him non-operatively. If he had decent range of motion, his strength's pretty good, I'd probably be less likely to get a scan initially and try something non-operatively, but I'd have a short leash in the sense that if by 4 or 6 weeks he's still complaining, you're probably going to need to get a scan to confirm that either A, there's nothing there, or B, there is something there you need to treat. You don't want to wait 6 months, because then you have a problem, because then you're trying to backtrack and try to determine if something is really was acute or chronic, or what's going on with it. An acute scan, you can see edema, swelling, all these things that would be more consistent with an acute injury. You can see in that first 4 weeks, so that gives you a time period to look at it. But once you start getting farther out, then he has a partial tear 6 months from now. Did he partially tear it when he fell? Was it there all along? I argue one way, the plaintiff, doctor's going to argue a different way, and then you're going to fight it out. So
I think as a good clinician, a subspecialist, you can get a good sense on physical exam what these patients have in the shoulder, other joints as well. But I think you can get a very good sense of whether it's fairly intact rotator cuff. Small partial tears are difficult, but you can get a sense from physical exam, definitely if a patient has a full thickness rotator cuff tear, and even partial tears. And I think it's better to go ahead and get the imaging, define the issue, and in my case, refer the patient on if necessary. Sometimes therapy, an injection is appropriate, but many times in my situation, not being a surgeon, I will get the imaging, make a decision, and refer the patient on, and that expedites the case.
But you should be able to get and I'm sure that Dr. deGrange will say the same thing with regards to studies and everything. You should be able to get your diagnosis based on the mechanism of injury, the history the patient gives you, and your physical examination. Ancillary tests are used usually to confirm what your diagnoses are, or to confirm that there's nothing there. I mean, if you're using an MRI scan to determine what's wrong with a patient, then you're not a good doctor. You're not doing the right thing. You should have a diagnosis. So anytime you do a test, you should know what the answer to that test is going to be. So you're already looking for the answer. So can't raise his arm up. I'm concerned he has a rotator cuff tear. That's what I'm looking for. Or he has good motion, good strength in his cuff, and he continues to complain even after being treated, and I don't think there's anything wrong there, and I'm trying to confirm that there's nothing there that I need to worry about. But if you're looking at it, if you're doing a scan throwing your hands up in the air saying, I have no idea, I'm just going to do an MRI scan, you're going to have a bunch of issues.
You're going to find things that are not relevant. And there is a school of thought in orthopedic surgery that no orthopedic evaluation is complete without appropriate diagnostic testing. I don't know if I ascribe to that dogma or that doctrine, but I would just say, again, just like Dr. Gross said, the orthopedic teaching is a good history and physical examination. You've got 90% of what you need to know.
In this case, two of the best tests that really look at rotator cuff tear are both negative. So to go from that and then to that diagnosis of full thickness tear just is a hard jump.
That's not a clinical diagnosis, and it should have been. That was inappropriate. You can't call something a tear based upon your physical examination. So it has to be confirmed by, just like a disc herniation has to be confirmed by an MRI. You can only call it radiculopathy in the absence of any appropriate diagnostic testing. So we get the terms mixed up. And these are the sorts of things that I have to wade through when I do the IMEs. There's a lot of mixed signals, missed findings, and things like that. But initially, I see your point. I think it's a good point, especially with backs, necks, and shoulders. Was this stuff there at the time of the injury? Because if you get it 6 months after the injury, chances are, if it's still 6 months out, you're going to be deposed because the guy's gotten a lawyer by then, and the lawyer's going to ask an appropriate question. Could it reasonably have been there at the time? Well, yes, it could have.
Okay. So, Justin, you've got a clinician who has made a diagnosis that's fairly aggressive and probably out of line with the history and physical examination. But most of the people in the room outside of some of the nurse case managers don't have a strong enough medical background to sort through that. Would I be amiss in saying that? Or you all got it? If you do, you're better than most of them. Because if you send him to the doctor and they send you these things, if it doesn't make sense to you, and you've got a reason why it doesn't make sense, what's your next step? Call the doctor. And what if the doctor doesn't make any sense? What if he says, I know because I've seen these before, and this is what they always turn out to be. I've had that happen. Where you don't question like that. I've seen 100 of these, and this is exactly what they look like. This is exactly what it turns out to be. I didn't need to do an imaging study. You heard that before?
Sure.
So what do? Do you go along with the doctor, knowing full well in your gut that what you found doesn't make any sense? What's your next step? What should your next step be?
Another doctor.
Another opinion from a doctor you trust.
It's not uncommon to see people have some sort of surgery based on the fact that the doctor says this was what's wrong with them. And I have patients come in every so often, they'll say that, and They don't have any imaging study, nothing to prove that what the case was, but they were, I know that this was a meniscal tear. So we ended up doing an arthroscopy of the knee, yet there's no MRI scan ever documenting a meniscal tear in that knee. But that doctor knew it was a meniscal tear, so they needed to have surgery. So.
And how often have you heard, it's been my experience?
Yeah.
And then one of my favorite sayings in the orthopedic realm is that some people wake up every morning and make the same mistake every day and call it their experience.
What logic do you use to determine the nature and extent of an injury?
Fuzzy. Fuzzy logic. The logic, again, has to be founded, I think, upon reasonable orthopedic or neurosurgical principles. Cause and effect doesn't make sense. Does the mechanism explain what the patient is trying to sell to you?
And was there really an injury that happened? You have somebody that comes in and says, I was at work today and I picked up a file and put it on top of a shelf and I have horrible shoulder pain. Well, they've done that every day they go to work.
Mm-hmm.
And what was different today than any other day when you picked up that file that weighs 2 pounds and put it up on this shelf? Is that really a mechanism of injury that could cause something to happen to the rotator cuff or not? And that's what you have to wade through, because people want to, and even in my patients that are not workers' comp patients, people always want to equate something happening to them. So if I have knee pain, I want to say the reason why I have knee pain this morning is because yesterday I did this, and this is what made my knee hurt, as opposed to being able to say, I'm 52 years old, I'm just old. I have knee pain. Sometimes things hurt, and that's what happens, So there you go. And that's what happens. And I think that everybody, no matter what you do, even if you go to your primary care physician, you want to have a reason why you have this. The reason why I have a sore throat is because yesterday I was outside, I went out to my car, I didn't have my coat on, and it was cold and it was raining, and this is why I have this. This is why I got this sore throat, and I have this virus or this bacterial infection in my throat. So everybody wants to equate something that has happened to them with some other event to make sense to them. So you have to look through that and wade through that when you're looking through these things, especially with these patients that come in with multiple complaints or have mechanisms that don't make sense. I bumped my knee on the front of a desk and now I have horrible, terrible knee pain and I can't walk. It doesn't make that much sense because they've probably done that before at home. So
I think if you get it, it's helpful to know, like Dr. deGrange said, how quickly did those symptoms come on? What were their initial symptoms? Those help in terms of looking at severity overall. Nature and extent, yes.
What can we do from our end to help you with this logic or come to a conclusion?
Document. That's all you can do. And if you're consistent in your documentation, I'm not looking for you. I tell lawyers this quite often when I'm undergoing a deposition. It's not up to me or for me to make your case. Ask me the right questions and I'll give you the truthful answers. So just document what you know to be true, and I can read between the lines.
And then a video can be helpful.
Yeah, we've got videos of all of our jobs.
Right, that's very important. Dr. Tripp makes an excellent point.
From a therapy standpoint, job descriptions are huge. If we ever can get job descriptions, it's the thing we want.
Okay,
so we know what they have to get back to you.
I'm going to ask this question. When does subjective complaints outweigh the objective findings?
It all comes down to the patient. It really does. That's an excellent question. When I first saw it, I'm thinking, what are you after here? And then the more I thought about it, it comes to what we do every day. Do you believe this patient? Or is he trying to sell you a bill of goods? And that's really what it comes down to. Especially with necks and backs where there's so much psychological overlay. It's hard to separate the wheat from the chaff, but unless they have some compelling neurologic deficit or an evolving neurologic syndrome, I don't pay too much attention to the subjective complaints. Everybody's got pain. We've all come to work when we've had the flu and when we're hurting, so I expect them to act like everybody else. So it does occur occasionally, but I don't make a living on it.
I think you have to really look at just objective complaints or objective findings rather, because if you start operating on subjective complaints, you can operate on everybody, and operate on a lot of stuff that doesn't need to be operated on, and it's not uncommon where somebody is sent to me as a IME, and they've had a rotator cuff repair done. I know the surgeon. They've done a great job. They have an MRI scan afterwards showing the cuff's intact. There's nothing else going on in that shoulder. They don't have any other provocative signs for anything else, yet they still have pain. And for me to say, well, subjectively you have pain and objectively everything looks good, but I'm going to stick a scope in there anyways, just to take a look around, because there might be something in there that somebody's missed. It's not, that patient's not going to get better. And that's probably one of the worst things you can do to any patient, is to operate without having a diagnosis. Just to say, I mean, I don't think I've, in 15 years, I don't think I can count on one hand if I've ever done a diagnostic arthroscopy. There's no reason to do a diagnostic arthroscopy. I need to know what's going on in the shoulder or knee before I do the arthroscopy. If I'm looking for something, how do I know if something's just a normal anomaly for that patient, or it's really abnormal? I'm just going to go in there and start cutting stuff out. They say, well, it doesn't look good to me. I guess it's bad, and they're complaining of pain, so I'm going to cut it out. So if you're doing a diagnostic arthroscopy for something, then you're behind the 8 ball, because you're not going to get that patient better. You need to know what's wrong. They have a cuff tear, they have a labral tear, they have a meniscal tear, and that's what I'm going in there to take care of. If you're saying I have no idea what's going on, but they complain of pain, so I just need to stick a scope in that joint, that patient's not going to get better. It's going to be a bad thing.
So I guess you wouldn't agree with the diagnostic spinal fusion then?
No, that'd be bad too. So.
Where this gets really messy, though, we're going to get into a case here shortly, that is mild traumatic brain injury or concussion management. Everything's subjective. There's very little objective data there. And so that is the exclusion here, is that everything is subjective, and that's where it gets very tricky. So.
And there's that small percentage, 1 out of 4, 1 out of 5, where they may have some very altered pain responses.
Right. There's a question I didn't ask before. I'm going to ask it now, and I think I already know the answer. You do too, but I'd like you to answer for the audience. What's more challenging for you as a physician, the treatment of the injury itself, or the patient's reaction to the injury?
Patient's reaction.
Patient's reaction.
Patient's reaction.
Patient's reaction.
Now, it should be obvious, but I'm going to ask the question, why?
It's what they perceive. It doesn't matter what I tell them. They could have imaging studies that are completely negative, but if they believe something's happened to them, they told their supervisor that floor is always wet and somebody was going to slip and fall and they were going to hurt themselves, and lo and behold, it happened to me, and this is what's going on, and I'm hurt. They're hurt, no matter what I tell them. If I get an MRI scan, it says it's normal, but there's something wrong with me, and you're missing it, doctor. And I told those people this was going to happen, and somebody's responsible for this, and somebody's going to pay.